Welcome to this deep dive on breast cancer and reconstruction. We're aiming to really cut through the noise and focus on the key points for practice.
Sounds good. Let's dive in.
So, starting with breast cancer itself, it's obviously a huge area. What are the main types we're dealing with in terms of invasive cancer?
Right. Well, the most common one you'll see is invasive ductal carcinoma. Definitely the majority.
Okay.
But then you also have ductal carcinoma in situ, DCIS, which is non-invasive but important, and invasive lobular carcinoma, less common but distinct, and Phyllodes tumors too.
Got it. And the causes, it's complex, isn't it? Most cases seem sporadic.
Exactly. Most breast cancers just happen. No clear inherited link. But then you do have familial clustering and, of course, the inherited genetic factors.
Like BRCA1 and 2.
Precisely. Those significantly increase risk. And for those patients, prophylactic mastectomy is a major risk-reducing option we discuss.
Okay. Let's dig into risk factors more generally. Can we categorize them, maybe by how strong the link is?
Yeah, that's a good way to think about it. So, strong associations, being female, getting older, definitely. A personal history of certain benign breast diseases.
Like atypical hyperplasia.
Yes, things like that. And those BRCA mutations we mentioned. Also, having dense breasts on mammography is a big one.
Okay, strong factors. What about moderate risk?
Moderate would include things like having multiple first-degree relatives with breast cancer, or maybe a history of high-dose radiation to the chest, perhaps for lymphoma treatment years ago.
Right, and then lower risk factors, lifestyle, medical history.
Yeah, a whole range of things fall into lower or less clearly defined risk categories. Lifestyle choices, reproductive history, hormone use. It all adds up, but the individual impact might be smaller.
And pathology reports themselves can hint at future risk too, right? Beyond just cancer diagnosis.
Absolutely. Certain findings, like lobular carcinoma in situ or atypical ductal hyperplasia, are definite markers for increased future risk. We classify these lesions based on that risk potential: low, moderate, strong.
Okay, so once cancer is diagnosed, how do we define its extent? Staging.
Staging is key.
Uh,
The main system is T&M. T for the primary tumor size and local invasion.
right,
N for lymph node involvement, are nodes positive, how many where,
okay.
and M for metastasis, has it spread to distant organs.
TNM, and that gets summarized.
Yeah, on it into summary stages, like local, meaning confined to the breast, regional, spread to nearby lymph nodes, or distant, meaning metastatic disease.
Makes sense. And beyond just the physical spread, the biology matters. Molecular markers.
Hugely important. We always check for estrogen receptor, ER, and progesterone receptor, PR, status.
Hormone receptors.
Exactly. And also ATR2 status, that's the human epidermal growth factor receptor 2. These dictate so much of the treatment pathway, especially systemic therapy.
And if all three are negative.
That's what we call triple-negative breast cancer, a distinct subtype with its own treatment challenges.
Okay, good overview. Let's pivot to treatment. Breast conservation therapy, BCT. How does that stack up against mastectomy?
Well, for suitable candidates, BCT, which is essentially a lumpectomy followed by radiation, offers equivalent overall survival to mastectomy. That's a critical point.
Equivalent survival, but recurrence.
But yes, there is a slightly higher risk of local recurrence in the treated breast compared to mastectomy. And there are contraindications, situations where BCT isn't advised, like inflammatory breast cancer or diffuse disease.
And sometimes during lumpectomy, surgeons do oncoplastic techniques.
Right. Oncoplastic surgery applies principles from cosmetic breast surgery, like reductions or lifts, at the time of lumpectomy. The idea is to remove the cancer effectively, but also reshape the breast for a better cosmetic outcome, especially with larger resections.
Interesting. Now, mastectomy, it's not just one procedure, is it?
No, definitely not. There's nipple-sparing mastectomy, areola-sparing, skin-sparing, all aiming to preserve parts of the breast envelope for reconstruction.
Right.
Then you have simple or total mastectomy, modified radical mastectomy, which includes axillary node dissection, and the older radical mastectomy, which is rarely done now.
And checking the lymph nodes. Sentinel node biopsy is standard.
Yes, sentinel lymph node biopsy is the standard of care for clinically node-negative patients. It identifies the first few nodes draining the tumor, highly sensitive and specific for staging the axilla, with much less morbidity than a full dissection.
And just to reiterate, survival rates really depend on that initial stage, don't they?
Absolutely. Early-stage disease has very high 5-year survival rates, which unfortunately decrease significantly with more advanced metastatic disease. Early detection remains key.
Okay. So after mastectomy, reconstruction becomes a major topic. Why do women choose it?
It's very personal, but common reasons include wanting to avoid an external prosthesis, feeling more comfortable in clothing, and restoring body image and self-esteem. The psychological benefits can be really significant.
Makes sense. And it can be done immediately or later.
Yes, either immediate reconstruction at the same time as the mastectomy, or delayed reconstruction performed months or even years later.
Why might someone not choose reconstruction?
Some women worry about complications, the extra surgery, recovery time. Age can be a factor for some, and sometimes there's concern it might interfere with cancer treatment or follow-up, although generally it doesn't impede surveillance.
Are there times when reconstruction just isn't possible? Contraindications?
Absolute contraindications are rare, maybe very advanced, uncontrolled cancer, but relative ones are more common. Things like active smoking, significant obesity, severe comorbidities, prior extensive chest wall radiation or surgery. These increase risks.
And patients need to be informed about these options, right?
Definitely. Patient education is crucial. In many places, like the U.S. with the Women's Health and Cancer Rights Act, there's a legal mandate to inform patients about reconstruction options.
And that includes insurance coverage.
Yes. Typically, mandated coverage includes not just the reconstruction itself, but also procedures on a contralateral breast to achieve symmetry.
Okay, so when you're selecting patients and planning reconstruction, what factors are you weighing up?
Oh, a lot. Patient factors are key. Their general health, support system, lifestyle, expectations for recovery.
Right.
Then cancer specifics, the stage, need for adjuvant therapy like radiation, the mastectomy itself, what kind of skin defect are we expecting?
Yeah.
Patient preference for size, donor site availability if using autologous tissue, the condition of the other breast, and of course, the surgeon's experience matters.
Let's talk timing. Immediate versus delayed. Pros and cons.
Okay, immediate reconstruction. The big advantage is often cosmetic. You preserve the natural skin envelope, potentially the nipple. It can feel psychologically better, maybe fewer surgeries overall.
But downsides.
Well, sometimes assessing flap viability right away can be tricky. If unexpected post-op radiation is needed, it can compromise the reconstruction, especially an implant.
And delayed.
Delayed reconstruction avoids any potential clash with adjuvant treatments. Final pathology is known, maybe lower immediate complication risk. But you lose the native breast skin, making reconstruction potentially more complex. There's the interim period without a breast mound, and it always means more surgeries.
Is there a middle ground?
Yes, something called delayed immediate reconstruction often involves placing a tissue expander during a skin-sparing mastectomy. Then, based on final pathology and adjuvant needs, you decide on the final reconstruction timing and type. Kind of hedges your bets.
Okay, let's get into the methods. Implants and tissue expanders are very common.
Very common, yes. The main prerequisite is having healthy, well-vascularized mastectomy skin flaps.
Advantages.
Generally lower initial cost, technically less demanding than flap surgery, no donor site scar, and usually shorter surgery and recovery times initially.
Disadvantages.
Higher long-term costs potentially due to revision surgeries. Risks include capsular contracture that's hardening around the implant rupture, infection. Achieving long-term symmetry can be challenging. They don't age naturally like native tissue.
And you mentioned one stage versus two stage.
Right. One stage is direct to implant at the time of mastectomy. Fewer surgeries, potentially, but less control over final size shape, maybe higher risk of skin necrosis or asymmetry if the pocket isn't perfect.
And two stage.
Two stage starts with a tissue expander placed after mastectomy. Then, over weeks or months, it's gradually inflated, stretching the skin and muscle. Later, a second surgery swaps the expander for the permanent implant.
What's the benefit there?
More control over the final volume and shape. Allows the tissues to stretch gradually. Potentially better pocket definition, maybe lower risk of flap compromise.
Can you walk us through expander placement, key principles?
Sure. Usually placed partially or fully submuscular, using the pectoralis major. Defining the inframammary fold accurately is critical. Closing any lateral dead space, often using serratus muscle slips for lower pole coverage.
How much do you fill it initially?
Usually a small initial fill, intraoperatively, just enough to take tension off the closure but not stress the flaps. Then outpatient expansion starts a few weeks later, maybe every 1-3 weeks, gradually adding saline.
Do you overfill it?
Often, yes. We typically overexpand by maybe 10–20% beyond the target volume to counteract tissue settling and create a bit more platosis. Then there's a dwell time where the expanded pocket matures before the second stage implant exchange. And remember, the expander shell itself has volume.
Right. What increases complication risk with implants expanders?
Several things. Preoperative radiation is a big one. Smoking, obesity, diabetes, Having very large breasts pre-mastectomy, these all stress the tissues.
What about chemo or hormone therapy?
The evidence there is less clear. They don't seem to be major independent risk factors for implant complications in the same way radiation or smoking are.
Does reconstruction interfere with cancer surveillance?
No. Studies show it doesn't delay detection of local recurrence or impact overall cancer outcomes. Surveillance methods might be adjusted slightly, but it's safe.
How do the results hold up long term?
Aesthetic results can be quite good initially, say at 3 years, but patient satisfaction can sometimes decrease over time, often related to complications like contracture or the need for revision surgeries.
Does radiation history impact that? Or laterality?
Definitely. Both having prior radiation and unilateral reconstruction, trying to match a natural breast, tend to correlate with slightly lower long-term cosmetic scores compared to bilateral non-irradiated cases.
What about techniques for larger or podic breasts with implants?
That can be challenging. Sometimes techniques like using a reduction pattern incision for the mastectomy or creating a deep epithelialized dermal sling for lower pole support are used, but these can also have higher complication rates.
Okay, let's shift to using the patient's own tissue autologous reconstruction. Pedicled flaps first, maybe the latissimus dorsi.
Sure, the latissimus dorsi or LD flap uses muscle and potentially a skin island from the back, rotated to the chest on its vascular pedicle, the thoracodorsal artery and vein.
When is it a good option?
Good for small to medium reconstructions, especially if implant coverage is needed after maybe a failed implant or thin mastectomy flaps. It provides reliable, well-vascularized soft tissue. The skin paddle is versatile. Donor site morbidity is usually minimal, though back weakness is possible.
Downsides.
High rate of seroma fluid collection at the back donor site is common. And importantly, it often doesn't provide enough volume on its own for full breast reconstruction, so it frequently needs to be combined with an implant.
Are there variations?
Yes, things like extended LD flaps to capture more fat, muscle-sparing versions, or even perforator-based flaps like the TDAP, thoracodorsal artery perforator flap, to minimize muscle sacrifice.
All right. What about the tram flap, the abdominal one?
The transverse rectus abdominis myocutaneous, or TRAM flap. This uses skin, fat, and muscle from the lower abdomen transferred up to the chest. It can be pedicled or free. Let's talk pedicled first.
Advantages of pedicle tram.
The big one is it can provide enough tissue for a completely autologous reconstruction, avoiding implants entirely. It can give a nice, natural, long-lasting result, and patients often appreciate the secondary gain of the abdominoplasty or tummy tuck effect.
Disadvantages sound significant, though.
They can be. Donor site morbidity is the main concern. Potential for hernia or abdominal bulge weakness because you take rectus muscle. Significant scarring on the abdomen. Risk of seroma, contour issues, recovery is longer. Often need mesh reinforcement of the abdominal wall. And the flap itself has a higher risk of partial fat necrosis compared to free flaps, especially in the furthest zones.
Perfusion zones. That's key for trams, right?
Absolutely. Classically divided into 4 zones based on blood supply from the deep inferior epigastric artery perforators traveling through the muscle. Zone I, closest to the pedicle, is most reliable. Zone 4, contralateral and furthest away, is least reliable and often discarded in pedicled flaps.
Is surgical delay ever used for trams?
It used to be, the idea being to precondition the flap's blood supply, but studies haven't really shown a clear benefit, especially beyond maybe 3 weeks. Not commonly done now.
Any tips for the pedicle dissection?
Yeah, always identify the deep inferior epigastric artery and vein, DEV lowdown. They can serve as a lifeboat. If the pedicle gets compromised, you could potentially convert to a free flap.
Common complications with pedicled tram.
Partial flap loss, particularly skin or fat necrosis in zones 3 and 4. Total flap failure is rare but devastating. And then the abdominal wall issues hernia, bulge, laxity.
Okay, now free flaps. Microsurgery required here.
Mhm.
Where do you hook up the blood vessels? Recipient sites.
Several options. The most common is the internal mammary artery and vein, IM-AIMV.
Pros and cons of IM vessels.
Pros. Usually good size match, reliable, accessible in the peristernal space, avoids axillary dissection if not otherwise needed. Cons. Can be delicate, vein might be small or absent on the left sometimes, respiratory motion can be a challenge, theoretical concerns about future cardiac surgery access.
Another common option.
The thoracodorsal artery and vein, often right there in the axilla after mastectomy. Consistent anatomy.
Downsides to thoracodorsal.
Can be damaged during axillary dissection. Might lead to a slightly more lateral breast position. Can be technically tricky depending on surgeon positioning.
Are there others?
Yes, less commonly used options exist, like branches of the axillary system or intercostal perforators, or even cephalic vein for venous outflow.
Let's Let's talk free tram flap specifically. How does it compare to pedicled?
Free tram, particularly the muscle-sparing or perforator versions like the DEP flap, has advantages. Blood supply is generally more robust because you directly anastomose the main source vessel, DIEAV. This means less risk of fat necrosis and partial flap loss,
On the abdomen.
less abdominal morbidity. With DAE, deep inferior epigastric perforator flaps, you take minimal or no rectus muscle, just the perforating vessels. So lower risk of hernia and weakness. No upper abdominal bulge from the pedicle tunnel. Easier flap shaping too.
Disadvantages.
Requires microsurgical expertise and resources.
Greater.
Longer operative time. Needs intensive post-op monitoring.
You mentioned DIEP. Are there classifications for muscle sparing?
Yes, different classifications exist based on how much muscle is taken with the perforators, from minimal muscle cuffs to taking a larger segment. The goal is always fascia sparing as much as possible during dissection.
Any tips on ensuring slap perfusion or abdominal closure?
Meticulous perforator dissection is key. Ensure no tension or kinking at the anastomosis. For closure, a layered approach, often with mesh reinforcement if significant fascia was taken or if there's laxity.
Complications specific to free tram dip.
Wound issues at either site. Fat necrosis still possible, though less than pedicled tram. Partial or total flap loss due to vascular thrombosis the biggest fear. Hernia is still a risk, though lower than pedicled tram. These risks are higher in obese patients.
Any lifeboat vessels here?
Sometimes the superficial inferior epigastric vein, SIEV, can be harvested and used as an additional or alternative venous outflow if needed.
Beyond tram deep, there are other perforator flaps.
Yes, many options based on perforators from other source vessels. Luteal artery perforator flaps, SGAP, IGAP, from the buttocks. Lumbar artery perforator, the LAP flap from the flank. Profunda artery perforator, pupae pop flap from the inner thigh, each with its own pros, cons, and donor site considerations.
Okay, big topic. Adjuvant radiation. How does that impact reconstruction?
Post-mastectomy radiation therapy, PMRT, definitely increases complication rates for almost all types of reconstruction. It damages tissue, impairs healing, causes fibrosis.
How do implants fare versus autologous tissue if radiation is given after immediate reconstruction?
Generally, autologous tissue tolerates radiation better than implants. Implants have significantly higher rates of capsular contracture, pain, need for removal, and poor aesthetic outcomes when irradiated immediately post-op. Autologous flaps also have higher complications with PMRT, but often fare better overall.
What about if reconstruction is delayed until after radiation is finished?
Similar pattern, although maybe slightly less severe than radiating an immediate reconstruction.
All right,
Irradiated tissue is just more challenging to work with for both implants and flaps.
let's look closer. Prosthetic reconstruction and radiation.
High complication rates, significant increase in severe capsular contracture, pain, asymmetry, poor aesthetics, patient dissatisfaction, often necessitates conversion to autologous reconstruction down the line. Many surgeons advise against immediate implant reconstruction if PMRT is highly likely.
What about pedicled tram and radiation?
Radiation doesn't seem to drastically increase total flap failure rates for pedicled trams compared to non-radiated ones. However, aesthetics, symmetry, and contracture scores are definitely worse with radiation. If PMRT is anticipated, delaying the tram is often preferred.
And free tram D with radiation.
Preoperative radiation, radiating the chest wall before a delayed free flap, doesn't seem to significantly increase major flap complications. But doing immediate free flap reconstruction followed by PMRT does have higher complication rates and more need for revisions compared to delayed reconstruction after radiation or immediate reconstruction without radiation.
So a key takeaway, if PMRT seems likely.
The general advice is often to consider delaying autologous reconstruction until after radiation is complete, or if doing immediate, counsel the patient extensively about the increased risks, especially with implants.
Okay, let's try to summarize some key take-home points. Immediate reconstruction planning.
Needs a multidisciplinary approach. Careful preservation of internal mammary perforators during mastectomy, if they might be needed as recipient vessels. Quality of the mastectomy, especially skin sparing, is paramount for good outcomes.
Tissue expanders.
Generally avoid in previously irradiated breasts. Partial submuscular placement is common now. Evidence for using a cellular dermal matrix, ADM, is still evolving, not definitively superior in all cases. High-risk patients prior radiation, smokers, obese, compromised flaps may be better to delay or choose autologous.
Pedicled tram.
Watch out for superficial epigastric vessels during flap elevation. Consider identifying the DIEAV as a backup. Ensure a wide subcutaneous tunnel for the pedicle. Bilateral pedicle trams have very high abdominal morbidity. Be critical of zone 4, maybe even zone 3 perfusion.
And free flap reconstruction.
Consider harvesting SciACIVE as potential backups. For unilateral DAP, you usually only need the ipsilateral hemiabdomen. If using thoracodorsal vessels, anastomose proximal to the serratus branch takeoff. Remember, technical error is the most common cause of free flap failure. Meticulous technique is crucial.
This has been incredibly comprehensive. It really highlights the complexity involved in breast cancer reconstruction decisions.
It truly is. So many variables. The cancer, the patient, the available techniques, the potential complications, adjuvant therapies. You have to weigh everything carefully.
And as you said, it's a field that's constantly evolving, with ongoing refinements and surgeon preferences playing a role too.
Exactly. Always learning, always adapting.
Well, thanks for sharing your insights in this deep dive.
My pleasure.